This is video number 2 about pain. Let's talk about physical dependence, tolerance, and addiction. Physical dependence is actually a normal response to long-term use of opioids. The body gets used to having that pain relief and you will become physically dependent. Tolerance is also a normal response. Opioid addiction is chronic neurologic and a biologic disease. Pseudo-addiction is a mistaken diagnosis of addictive disease, but it's where you have demanding behavior for medications, not from addiction, but maybe from uncontrolled pain. Drug formulation terminology. You have short-acting, fast-acting, and immediate release medications. Normal release, the onset is about 30 minutes, and it has a short duration of 3 to 4 hours. All right? So any of those, short-acting, fast-acting, immediate release, or normal release. That's 30-minute onset and only lasts 3 to 4 hours. If you have modified release, extended release, sustained release, or controlled release, these are released over a longer period of time. And you've got to remember, with anything that says ER, SR, or CR, you do not crush it or break it. These are extended release, and they're meant to dissolve slowly. If you break these up and give it to the patient, you could cause an overdose situation. Right. Morphine. All other opioids are compared to morphine. It's hydrophilic, which means it's readily absorbed in aqueous solution. It comes in a lot of routes for administration, and the most common drug used, it is the most common drug used in PCAs. Okay, fentanyl is lymphophilic, so it's really good transdermally, but patients may need other medications for the first 24 hours until the fentanyl gets in the system. It has a rapid onset. It's good when rapid analgesia is desired, and it's recommended with patients with end organ failure, and it's used in critically ill patients because it has less hemodynamic side effects. So don't get confused. The 24-hour onset is for the transdermal. If you use this in any other route like IV, it's a rapid onset. Okay? Hydromorphone or Dilaudid, it's a good alternative to morphine. It's the first choice if you don't want to give morphine, like if they're allergic or something, and it can also be used in a PCA. Oxycodone, Percocet, or OxyContin. It's usually in combination with acetaminophen or ibuprofen, and it's good for mild to moderate pain. On its own, like without being mixed with ibuprofen and acetaminophen, it's good for moderate to severe pain. It's kind of a good multimodal treatment for post-op pain. So hydrocodone, like Norco or Vicodin, it comes mixed with acetaminophen and ibuprofen, and it's for mild to moderate pain. It is the most commonly prescribed of the medications, the oral meds, and you have to watch closely for the daily amounts of non-opioids that are in it. So like Tylenol and ibuprofen, how much can you give in a day? You need to watch that with the hydrocodone. Methadone, you might give this while titrating medications, but you have to watch really closely for oversedation. And it can interact with a large number of medications, so watch that methadone in that way. Dual mechanism analgesics. So although they're not true opioids in their action, they are scheduled drugs. Okay, that's tramadol and tapentadol. Okay, they bind really weakly to those mu opioid receptor sites, and they block the reuptake of serotonin and norepinephrine. So that leaves more serotonin and norepinephrine in the body, and serotonin is a feel-good, as well as norepinephrine. They make you feel good. These are for acute and chronic pain, and they can react with other meds that block the reuptake of serotonin, like SSRIs, and they rarely may cause serotonin syndrome, which is agitation, diarrhea, heart and blood pressure changes, and loss of coordination. Tapentadol is new, and it's more favorable because it has less GI side effects than the opioids. Alright, opioids to avoid. Meperidine or Demerol is used to be one of the most common opioids to give, but it actually has really a lot of side effects. And it's not used as much anymore that we have the better opioids. If you do use it, don't use it any more than 48 hours in doses not to exceed 600 milligrams in a 24-hour period. Its metabolite, which is normeperidine, and what is a metabolite? It's a substance formed in the metabolism of the drug. So its metabolite can actually cause delirium, irritability, tremors, and myoclonus, which is spasmodic jerking, and generalized seizures. Okay, so it's really a poor choice in the elderly, and it is on the Beers criteria list because it's eliminated through the kidneys, and the elderly usually have decreased kidney function that can cause that toxic metabolite to stay in the system longer. All right, codeine. Combined with Tylenol, it used to be used a lot, but it's been traded off for meds with less side effects like Percocet. Intraspinal analgesics includes both epidural and intrathecal injections or drips. So epidurals. Epidurals can be for acute pain or chronic pain, as well as post-op pain. They can be things like morphine, fentanyl, hydromorphone, usually in combination with something like bupivacaine or ropivacaine, and this multimodal dosing means less of each meds, just like any other multimodal treatment of pain. So remember that the canes, anything with the cane at the end of it, are your numbing medications. So you can see how that with an opioid would be a good choice for post-operative pain. Intrathecal injections. These are usually a single bolus, or it could be a continuous bolus via an implanted pump for chronic pain. Morphine is the most used intrathecal injection, and there's a small amount of the drug that's needed because it's so close to the spinal cord. Okay, so side effects. Depends on the drug used. So if opioid, then we have the opioid side effects. You could have urinary retention. You've got hypotension, numbness and weakness at the lower extremities. So any of these like epidural or intrathecal type treatments require frequent neuro assessments, and most of these problems can be fixed by just decreasing the dose. So if they've got an epidural and you notice some urinary retention, the doctor might decide to decrease the dose and see if that won't help. They're going to have decreased ability to bear weight and or bowel and bladder dysfunction. And that can actually indicate an epidural hematoma or abscess, which can cause paralysis. So if all of a sudden they have a decreased ability to bear weight, they were doing pretty good and now their legs won't even hold them, or they're losing control of their bowel and bladder, that's something you definitely need to report to the doctor because you might suspect an epidural hematoma or an abscess. So be sure and read chart 4-2 about the intrathecal pump for managing cancer patients. Be sure and read over that. What are the effects of opioids? What are the side effects, the adverse effects? Constipation, nausea, vomiting, pruritus. What's pruritus? Look it up if you don't know. You should know that one. Sedation, respiratory depression. This is less common, but it's actually the most concerning. All right. So it can cause itching, and this can be triggered by histamine release and activation of special itch-specific receptors in the spine. So that's another adverse side effect that it can cause. Anticonvulsants and antidepressants produce analgesia, and the way they do it is by blocking the sodium and calcium channels in the central nervous system, and thereby diminish the transmission of pain. Remember, any kind of blockage of that signal from wherever the injury or infection has occurred to the brain is going to block pain. So one of those medications is gabapentin or Neurontin, and pregabapentin, which is Lyrica. And these are the first-line analgesics for persistent neuropathic pain. These are nerve pain medicines. So they're frequently added to the post-op treatment to combat any kind of neuropathic component of nerve pain. The antidepressants, they block the body's reuptake of serotonin and norepinephrine. There are two groups of antidepressants, the tricyclic antidepressants or TCAs and the newer SNRIs or serotonin norepinephrine reuptake inhibitors. Evidence-based guidelines, and we're always trying to look at that evidence-based practice, right? So evidence-based guidelines recommend the TCAs dispiramide and nortriptyline, and the SNRI duloxetine, which is Cymbalta, and venlafaxine, which is Effexor, as first-line options for neuropathic pain treatment. So, you know, that multimodal way of treating pain. We don't always need an opioid. Maybe we need one of these antidepressants that kind of leans towards helping with pain. All right, so the tricyclic side effects, you're going to have dry mouth, sedation, dizziness. You may have mental cloudiness, may have some weight gain, orthostatic hypotension, and constipation. So because of the orthostatic hypotension and the risk for falls, this is a poor choice for the elderly. It can also cause cardiotoxicity for those with heart disease. Okay? SNRIs are better tolerated. Their side effects can be nausea, headache, sedation, insomnia, weight gain, impaired memory, sweating, and tremors, but they are usually tolerated better than the tricyclic antidepressants. Okay. You can also use local anesthetics. So the way these work is they block the generation and conduction of nerve impulses. These are things like lidocaine patches, on for 12 hours, off for 12 hours. These are things like topical anesthetic creams like EMLA or EMLA cream to temporary numb areas. They use that a lot for IV insertions to decrease the pain involved with that, and they'll use that on children a lot. It has to be on for 30 minutes before you attempt an IV. Liposomal bupivacaine is for regional injections. All of these local anesthetics are for temporary pain relief, and they can be used for continuous nerve blocks by infusion called a perineural regional analgesic by PCA. So it's called PCRA, or patient-controlled regional analgesic. Okay. Use of placebos. Basically, don't do it. It's not ethical, and it should be used in research only, okay? That's any medication or procedure which produces an effect because of its intent. It's used as a control in research, and any other use has ethical and legal implications. This violates the nurse-patient relationship. Can you imagine if you were giving a placebo instead of a pain medication and the patient found out? They will no longer trust you, that is for sure. And it also deprives the patient of appropriate assessment. So just don't do it, not even if the physician asks you to. It's not ethical. Non-pharmacologic management. What can we do that doesn't include meds for mild or moderate pain? Well, PT, OT, aqua therapy maybe, water therapy, acupuncture. I know when my back is hurting, speaking of that aqua therapy, a good long soak in a warm tub really helps. Low impact exercises like slow walking and yoga. Functional restoration like some of the chronic pain type programs so that you can learn coping skills, etc. for your pain. Have you ever used a TENS unit? That's a transcutaneous electrical nerve stimulator. It really can help to relieve some chronic pain. It kind of gives you a little jolt of electricity that your body tends to pay attention to. It's not painful, or well, it can be if you crank it up too high, but it's usually not painful. And it gets the brain's kind of interferes with that message of pain that's going to the brain. Vibration is another therapy for mild to moderate pain. Heat, cold, or pressure can help. Massage also. There's also a thing called a spinal cord stimulator. This is invasive, but it's really sometimes very helpful for intractable neuropathic pain syndrome. Okay, so they go in there and they just put a little stimulator into the or near the spinal cord, and you have a control outside of the body, and it gives a little continuous electrical current in there that kind of helps reduce or block the pain from going to the brain. All right, physical interventions. Here are some examples. We talked about them already. I'll read over them one more time. Physical therapy, occupational therapy, aqua therapy, functional restoration, acupuncture, low impact exercises such as walking or yoga, and cutaneous stimulation like a TENS unit. Okay, cognitive behavioral strategies. All right, so what can we do? What are some other things that can kind of help our pain or get our mind off of pain? Prayer, relaxation breathing, just those slow, deep breaths, totally relax it out. Artwork, just working on something that's artistic. Reading, watching television, mindfulness, meditation, guided imagery, hypnosis, biofeedback, and virtual reality. You need to be sure and read over the areas on home care, self-management, and healthcare resources to make sure that you're familiar with those. And I just said this, read over these areas, the home care management, self-management, education, and healthcare resources in your book. So on the next slide, there will be a few questions for you to answer, and that is your assignment for this PowerPoint video. So just do those few questions and then move on to your next video. You're doing great. Keep going.